are the pioneer of physiology in India. Ramji Singh sir, Dr. G.K. Pal sir, Dr. K.K. Deepak sir, Dr. H.N. Malik sir was here yesterday. And these are our teachers. So I just wanted to say that whatever we are because of our teachers. Whatever I am today, it is because of my teachers. They guided us, they told us what to do. That's how we are here. So I wanted to extend my gratitude to all the teachers who guided me, and I am here because of them only. Can you give me that? Okay, thank you. So it's working, it's not working actually. So I'll like to start my presentation with this picture. So can anyone identify this picture? This is the Alfred Nobel Medal given to a scientist for a work in a field, extensive work, and they used to get the Nobel Prize for that. Very difficult to identify this man because this is around 100-year-old picture of Dr. A.V. Hill. And actually, he was the exercise physiologist who got the Nobel Prize. So basically, I wanted to say that he is the first and only exercise physiologist to get a Nobel Prize for his work. That was way beyond 100 years. Okay, so we got Nobel Prize in exercise physiology only once because of the work of this man, Dr. A.V. Hill. What he did, he basically saw the changes in the temperature in a muscle during the contraction, around 0.003 degrees centigrade change in a millisecond. He recorded that, and because of that work, he got this prize. This is the picture when he visited India in 1944, and he is sitting with our Indian scientist, Dr. S.S. Bhatnagar. We used to tell him the father of laboratories of India because he was the first person who started establishing the laboratories in India. That's how our government honored him with releasing a stamp for his name on 1994. So let's go back to our topic, that is the exercise physiology. So since yesterday we are having lot of sessions on various things, holistic health, diets and all. So just I wanted to convey this message to you all, especially the younger ones, that whatever you preach, you practice. This is the picture when I did my sports medicine diploma from NIS Patiala, that is called the hub of sports sciences and sports in India. That is the biggest sports hub in Asia. That is National Institute of Sports, Patiala. You have seen various movies like Dangal, you have seen, it is there mentioned there, NIS Patiala. So I did my sports medicine from there and then worked there as a sports physician for 2 years, from 2013 to 15. And during that, I used to go to various places as a posting, like Sonipat, and then Sai Shilaru. So basically, this is a high altitude center at Shilaru, where I used to go with the team for high altitude training. So this is actually my judo team at that time. If you can see, he is the coach, chief coach at that time. Now he's associated with other teams now, other association. But he was then the chief coach of the judo team. And I'm telling you, he was the fittest coach of any team across India at that time. He was around 45 years old and he used to run like anyone, better athlete than these athletes at that time. Another coach is there, Rahul Dravid. He is also very fit, but Jeevan sir was also very fit. This is Sushila Kumari from Manipur, a judo player and a world championship medalist right now. So what is exercise physiology? So if you see, in exercise physiology, we tend to assess the changes occurring during the exercise in the body. Whatever changes, BP changes, heart rate changes, those are called exercise physiology. So there are different aspects of exercise physiology. One is environmental physiology. If you see high altitude physiology, that comes under environmental physiology, because environment play a very important role. If you are running in a hot, humid condition, that will affect your body. If you are running in the cold condition, you are doing exercise, that will affect your body. So another is environmental physiology. You see, there is a DM course in high altitude medicine at AIIMS Rishikesh. Dr. Latika Mohan madam is working very nicely in this field. Another discipline is sub-discipline of the exercise physiology is sports physiology. In sports physiology, we take these principles of exercise physiology and then use them for enhancing the sports performance. That's what we are trying to do now. I learned that technique from the various postings, like I worked in NS Patiala, then under Dr. Pralay Majumdar, exercise physiology, renowned exercise physiologist of India. He worked there as a head during my posting in the Sai Bangalore, he was there. So I learned these techniques and learned how can we use to enhance the sports performance using the sports physiology. So one of the part of this assessment is cardiopulmonary exercise testing. So as you see, the topic of this conference is holistic health. So apart from talking about the CPET testing, cardiopulmonary tolerance testing, I'm also going to tell you some of the benefits of exercise in the disease conditions also, old age also. So I am also going to take a holistic approach. Okay. So let's start with the CPET first. I'll describe you what is CPET, how can we do the CPET, what are the instruments you needed to do the CPET, how can you interpret the CPET. Okay, so these are the things I'm going to discuss in the CPET right now. So basically, what is cardiopulmonary exercise tolerance testing? So basically in this testing, you are going to put the stress on your body. You will ask the subject to do the exercise. You can use a treadmill, bicycle ergometer, any type of instrument to put body on a stress and then see the changes in the BP and the ECG. That is called the CPET testing. Okay, so cardiopulmonary exercise testing is a dynamic non-invasive assessment of cardiopulmonary system. So there are different protocols are there to do this. I'm going to describe that also. For that, like in cardiology, they do their own CPET testing for pre-operative assessment of the fitness. Before going any major surgery, they also do that CPET testing. As a physiologist, you can also do the CPET testing if you are trained in that. Why? Because risk is involved. At the time of CPET testing, you can have any ischemic event. So you should be trained in that. Then only you proceed with that. Otherwise, you need a cardiologist to do that. We will go into the risk stratification also. Then CPET goes further to quantify the degree and nature of the physiological deficits. Okay, if it is there, you have to see the CPET data, you have to look at it, and then you have to say it is normal or is there any deficit. We are going to discuss that. So basically, what are the indications of the CPET? If you see, in a clinical setting, most commonly a person with unexplained dyspnea will come to a doctor and tell them, I have this problem. Nobody knows what is the problem. Respiratory problem, heart problem, what is the origin? So generally for unexplained dyspnea, CPET testing used to be done. Okay, in sports physiology, we tend to do it for assessment of the VO2 max. Okay, maximum oxygen consumption, volume of maximum oxygen consumption during the exercise, that is called the VO2 max, that we assess in an athlete. Okay, and VO2 max tend to tell about the capability of that athlete. Okay, so in CPET, apart from the clinical diagnosis, this is another aspect of CPET we do in sports persons. Okay, so unexplained dyspnea, evaluation of cardiovascular diseases, respiratory diseases, in clinical setting, these used to be things. Then exercise prescription. If you wanna give exercise prescription for a specific goal, like wanna decrease weight, you wanna maintain the fitness or improve the sports performance, the first what will you do? You will assess that subject with the help of the CPET, like where they stand. What is the VO2 max right now? 20, 25, very poor. You wanna improve? Go to aerobic exercises. Then we will see in 1 year where are you. Okay, so like that for exercise prescription we tend to give. I'll give you that principle, fit principle we follow for exercise prescription. I'm going to describe that also. Then exercise tolerance, how much you can tolerate. Why we are talking about the indication? Because there are certain contraindication to do the CPET testing. In some, you cannot do that. Like absolute contraindications are there. In some relative, if benefits outweigh the risks, you can go for CPET testing. If you are capable to manage the risk, or you have the support of cardiologist with you, you can go ahead with that. Like absolute, like if you have acute MI, 3 to 5 days, within 3 to 5 days you cannot do that. Like a person came to you with chest pain and you told, okay, we want to assess like you have MI or not, or you have angina attack or not. You cannot do that. Okay, so if subject is coming with a complaint and it is an angina attack, if you see, you cannot do the CPET to assess that subject. Okay, so like that, absolute contraindications are there. Then asthma, syncope, some of the things comes under the category of absolute contraindications. Some of the relative, like hypertension. Okay, so if BP is more, then what you have to do? You have to see the benefits. If benefits outweigh the risk, then you can go for that, but you have to continuously, online assessment should be done to prevent any adverse event, because risk of adverse event is there. Okay, although it is very less, if you see complication during hospitalization is less than 2 in 1,000, major cardiac event 1.2 per 1,000, 10,000, or mortality 2 to 5 per lakh, but it is less, but it is still there. That's why risk assessment is very important. So how will you do the risk assessment? With the help of a very specific chart. So this is the CPET risk assessment chart, in which you have to divide your patient into 3 categories. Routine patient with very low risk, moderate risk, and high risk, on the basis of the clinical condition of that subject. If you are a CPET clinician, you have to do this risk assessment first. Stratify. Okay. Ask first question, is it essential? Is there any other mean you can diagnose the patient? If it is there, don't do the CPET. It can aggravate the problem. Don't go for it. If any other thing can be done, don't go for CPET. If it is not there, if you are going for the CPET, then see the benefits. If it outweighs, you will go. If it not, think about something else. Because although it is non-invasive, but it is risky procedure. Okay, benefits are there. You are going ahead with that. Okay. If it is a routine test with a stable cardiac status, stable hemodynamic status, no problem, then you can go ahead with the low risk, routine test. But if it is not, other problems are there. Abdominal aortic aneurysm is there. Pulmonary hypertension, aortic stenosis, these come under the moderate risk. If condition is more severe, example, unstable cardiac status, ruptured or leaking aneurysm, untreated pulmonary embolism, these are the conditions which comes under the highest risk. What you have to do? You have to take the help. If it is a routine, low risk, cardiac and hemodynamic status is okay, normal. If you are capable enough to do that yourself, you can go ahead with the test, no problem. If it is a low or moderate risk, then you have to take in account the cardiologist. You have to talk with them. If any other alternative is there, think about the alternative. If it is not there, in the presence of those cardiologist or someone, you have to go with the test. So that's how you have to do the risk assessment and stratification in the CPET. Pre-test patient instructions are very important. What do you have to tell the patient? What will you tell? To decrease the risk of any incidents during the test, what you have to say the subject or patient? You have to tell them, refrain from exercise, have proper sleep, do not come empty stomach at least 2 hours before, take a small meal or light meal, like that. Empty stomach you should not do. Okay, maintain hydration, avoid caffeine. There is a list we have to follow. Okay, in the pre-test patient instructions. Then during the test, some of the criteria are there in which you have to stop the test. First and foremost is if patient or subject is saying that he feels uncomfortable. That is the first and foremost thing. Beginning itself, before doing the test, you have to tell the subject at any point of time, if you don't want to continue the test, you can stop. No problem in that. That is the first criteria. Then the second criteria comes with these things. Continuous ECG is going on, continuous BP is monitoring is going on. Then you have to see if there are changes in the ECG, like symptomatic changes with the chest pain. If there is a more than 2 mm ST depression, if you see this is the ST segment, if there is a depression and that is more than 2 mm symptomatic, then you have to stop the test. And if it is more than 3 mm asymptomatic, you have to stop the test. Means asymptomatic 2 mm is not the criteria. If it is more than 2 mm and symptomatic, then only you have to start. If it is more than or 3 mm with the symptoms, asymptomatic, then you have to. ST elevation of more than 1 mm, you have to stop the test. Hemodynamic status is not maintained, there is a drop in BP, you have to stop the test. So these are some of the criteria: arrhythmia, fall in BP, severe desaturation, SpO2 less than 80%, loss of coordination, mental confusion, dizziness. If these symptoms appear, then you have to stop the test, because you are continuously monitoring the hemodynamic status of the subject. And if there is any changes in ECG, BP, SpO2, you have to stop the test. Then, how will you say that subjects has done their maximum effort? They put their maximum effort. Some of the criteria is there in which you can say he has done their maximum. Otherwise, if he voluntarily not putting the maximum effort, then you have to again do the test next time. So these are some of the criteria by which you can assess the maximum effort put by the subject or not. What are those? Like achieves a play 2 in the VO2. Like they maximally achieved it, then the play 2 appeared. Thank you very much, sir, for your presence. And we are very much, sir. Sir. So if he has achieved the VO2 play 2, then we can say, okay, maximum effort was maximum. Heart rate reaches to the 90% of the predicted maximum heart rate. Okay, so if he has reached 90% of the MHR, okay, no problem. If it is less than that, then effort is not maximum. Then if there is evidence of ventilation limitation, maximum ventilation has reached, means breathing reserve was less than 15%. So okay, maximum ventilation is there, okay, maximum, like that. Then breathlessness score is there, Borg scale for the leg fatigue is there. So you have to ask the subject, if he's saying that I am feeling pain or I am fatigued, then you have to assess the fatigue, how much fatigue he feels. There are different scales, like original Borg scale is there or modified Borg scale is there. Okay, so original was around 6 to 19, they modified it 0 to 10. So 0 is very low to 10 is very highly feel fatigue. So like that they divided. So you have to ask, like how much you feel, very hard, less hard. So you have to divide. Then peak exercise blood lactate concentration. If you are taking blood lactate, because like blood lactate analyzer is there, we used to do that continuously at every 2 minutes. We have to assess the blood lactate. If it is more than 8 millimole per liter, you have to stop the test. Or maximal effort was there. So like that. So these are some of the equipments I have worked upon. Like this is the instrument lying there is in Delhi. Okay, CPET. Similar instrument we had at AIIMS Raipur, and right now we are buying metabolic cart in AIIMS Patna also. I am working there as faculty right now. Apart from that, you can have a cycle ergometer or rowing ergometer. So apart from treadmill, you can use rowing ergometer or bicycle ergometer also to assess the CPET or do the CPET, because maybe some of the subject will not be able to run in the treadmill. Like if somebody has a 120 kg of weight, so there will be leg fatigue. There will be a leg fatigue very early in the exercise. He will feel like I am having pain now, I cannot continue the CPET. How will you assess their cardiovascular system? So you can go for bicycle ergometer rather than the treadmill. So like that. So there are different types of protocol defined. Most commonly we tend to use Bruce or modified Bruce protocols. Okay, as you can see, Bruce, modified Bruce, Norton protocols are there. Most commonly we used to use Bruce or modified Bruce. Why Bruce modified Bruce protocol is modified? Because they decrease the intensity. So if I'm not going into too much detail, but if you see for the stage 1, in both Bruce and modified Bruce, speed is same, but the grade of inclination is less in the modified Bruce. So in the beginning there was a 10% of inclination in the treadmill, in the Bruce, but that was decreased so that patients in the beginning can have easily start the test. Okay, like that. Normal people we tend to start with the Bruce protocol, no problem. So other like YMCA protocol, rhythmic bike test, so these are for the bicycle ergometers. There are lot of protocols are mentioned. Then if you see during the testing, what are the different components of the test? Resting phase, unloaded, incremental exercise, recovery. So if you see this graph, these are different phases of a test. So in the rest phase, you will put everything, mask and all, and let the subject to have a breathe through that, so that he will be like, okay, after 2 to 3 minutes, he will be all right, no problem in breathing and all. He's like, okay. Then we will go with the unloaded phase, in which slowly we'll increase and he will walk. A subject will come to you and you will ask him, have you walked in a treadmill before? He will say, no sir, I haven't. So what you will do? You will start the treadmill, let him walk, then we will start with the loading phase, in which loading phase you will slowly increase the speed. Okay, slowly increase the speed. And when there is a peak, VO2 peak, HR max is reached, then the recovery phase, you will slowly stop the test, in which you will slowly decrease the speed and the inclination. So these are different phases of the CPET testing. Similar type of data you will get. This is the data of a subject at our lab. So I'm showing you similar type of data and similar type of graphs you will get in your CPET. Okay. So in data, what will you get? So in data, you will see how much time you have spent during a CPET testing. 11 minutes, 10.5 minutes. How much VO2 max? What is the VO2 max? How much maximum VO2 reached? So it is around 18.5. It will give you the predicted value also. So see, very poor. The fitness of that subject is very poor. Okay, predicted was around more than 45. It is only 18.5. So percentage predicted is only 44%. Okay, so we tend to say if it is more than 85, that is normal, 85%. If it is less than that, that is abnormal. So here it is only 44%. So very, very poor. Okay, like ventilatory threshold, so anaerobic threshold, ventilatory threshold, when the oxygen consumption was less than the CO2 production, or CO2 production was increased more than the oxygen consumption, we used to tell. So there is a value 1.6. Okay, then heart rate reserve. Okay, so maximum heart rate was 147. So for that subject, it should be more than 165. So effort was not maximal. At least more than 80 or 90% should be there. The criteria is more than 90% of the maximum heart rate should be reached. So only it should be more than 165, but it was only 147. So effort was low. Okay, like that. Then we will discuss more about that. This is the normal parameters. Like this summary you will get, in which everything will be mentioned. How much time, what protocol was used. Like see, modified Bruce protocol was used. This was the name of the treadmill track master and also this was there. These various types of graph will be there. Okay, what is the ventilation VCO2 ratio? What is the ventilation at that point? That was the maximum voluntary ventilation MVV. Various graphs you will get. Okay, these will tell different things like respiratory quotient 1.49. Okay, VO2. See, during the exercise, simultaneously increase and decrease in the VO2 and VCO2. So both the things are there. So you see, slowly and slowly CO2 is rising, and it is the maximum during the maximal effort. It was the VCO2 was more than the VO2 during the maximum exercise. So that is there. Means RER was more than 1. If it is reaches more than 1.1, then you have to stop the test. So this is also criteria. So that is there. So these type of graphs you will get. So now you got all the values. A subject came to you with an unexplained dyspnea. You assess the subject. VO2 max was 80.5. That is very less. 44% of the predicted. Maybe maximal effort was also not there. 147 was the maximum heart rate reached. It should be more than 165. So maximal effort is not there. Chalo, it was unexplained dyspnea. So we'll try to interpret now. So in the interpretation, some of the things you have to cover up. Okay, starting from the beginning, you have to cover up with everything. Okay, so let's start with the first point. What was the reason CPET performed? Have you done the CPET with a reason? Yes. There was a case, there was a cause. That's why it was done. Okay. What protocol was used? Okay. Modified Bruce was used. Okay. Maybe characterize the current CPET complete. I don't think so. Effort was not maximal. Okay. Did the patient have an impaired exercise capacity? What is the level of VO2, AT, oxygen pulse? Okay. So you have to see. On the basis of your values, you have to tell 18.5 very poor, very poor. VO2 max is very poor, 44% of the predicted. Does the patient have any hemodynamic instability? So is there any change in the ECG or BP? Because of that, patient had any episode of mental dizziness or drop in the BP? Did the patient have any ischemic ECG changes? Changes in the ST segment, more than 1 mm, you have to stop. In the ST elevation, more than 2 mm with the symptom, you have to stop. ST depression. Okay, is there anything like that? Did the ventilatory system participate in patient impaired exercise capacity? What is the ventilation maximum? What is the VCO2 ratio? So then did the test provide any prognostic information? So on the basis of that, can you make a diagnosis? Which one is involved? We'll talk about that. So like that. So one criteria, it is very important. Normal criteria is respiratory rate should be less than 60 beats per minute during the maximum exercise also. If it is not there, means there is a problem. Okay. So this will be the continuous ECG report, and you will get to see what are the changes. If you see, every lead is mentioned, and every lead ST segment elevations are mentioned. Okay, so if you see ST level in mm and slope millivolt per second. So you can see in every lead you will see how much ST level is there. Okay, so plus minus, if elevation is there and depression is there, it will be continuously monitored. Okay. So now risk stratification, in which on the basis of the peak VO2, that is the VO2 max, peak VO2, you will divide the subject and then you will try to make the diagnosis. So there are 3 criteria: less than 10, 10 to 18, more than 18. So our subject had the 18.5 VO2. So it will come under the low risk. More than 18 or 18 is the low risk. Okay. If it comes under the 10 to 18, then you have to see the VCO2 ratio. Okay. So what was the VCO2 ratio for our patient? It was around the 31.6. 31.6 was the VCO2 ratio. So VCO2 ratio, if it is less than 35, it is moderate risk. Okay. So if we take this subject with less than 18, if it was VO2, peak VO2 was less than 18, then this is moderate risk. But if it is more than 35, then you have to go for the PVO2. Okay. And if RER is this, you have to testify into the risk, high risk or low risk. So on the basis of the PVO2, we can say the subject fall under this category. So these subjects fall under the low category. As you know, his peak VO2 is 18.5. Okay, all the predicted is very less, 44%, but still fall under the low risk. Okay, so like that. Then differential diagnosis of the axonal dyspnea fatigue. On the basis of this chart, you can make a diagnosis of that subject. Okay, as you can see, what was the peak VO2? It was normal or low? We already know it is low, less than 85% predicted. It was only 44%. If it is normal, then it can be because of anything, anxiety or obesity. But it was not. It was because of